From a healthcare leader, in my opinion, the best thing you can do is to go out and actually see what your staff are doing.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm your host, Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management for Professionals. Today, I'm excited to be with Dr. Adam Probst. And Adam comes to us from Baylor Scott and White Health. Adam, I believe you have a PhD in human factors.
Yes, sir. Cognitive engineering, human factors.
That term, human factors, I've heard that used before. Above the neck, below the neck. Have you heard that?
I have, yes.
So kind of explain the difference between those two things.
Sure. So kind of a somewhat quick history lesson would be that human factors, the field has actually been around since World War II. Most people don't know that. It was actually established by the Air Force as a cognitive engineering lab. So it would be above the neck. The reason it was started is a lot of our test pilots back then, as we were trying to train and test out new equipment, were having a lot of fatal accidents, unfortunately. And so the Air Force realized that, well, if this many different types of people are having these accidents, these highly trained pilots that have spent years doing this, it's probably something to do with the design of our systems that is causing these errors, that we're not supporting the pilots above the neck in terms of giving them the information they need from either reading the dials or understanding the processes and procedures, that type of thing. So where human factors kind of diverges a little bit from ergonomics as an example, is that, ergonomics obviously is focused on the more below the neck physical environments, that sort of thing, where human factors kind of looks at it as a blending of two different fields. It's what you would call everything from the empirical side of psychological research. So our cognition, our perception, decision-making, motor control, how we interact with the world around us, basically. And it takes all of that and applies it with industrial and systems engineering and design. So basically, in a nutshell, we know what people are good at naturally in terms of information processing and the way our minds work. And we know what people are bad at naturally. And so we try to design systems, processes, technology, workflows, that kind of stuff to take advantage of what we're good at, but help protect us from what we're bad at. And so, there's been it's all over the field, but it's currently exploding in healthcare right now. When I started in grad school back in 2006, you might be able to find one or two health systems that had somebody doing human factors work, but it was all research. Nowadays, you're starting to find that there's dozens of healthcare systems that are employing people like me full-time, formerly trained human factors engineers that are working in a variety of domains. Could be, biomed type areas. Some are doing Lean Six Sigma. Some of us are like me that are in the unapplied patient safety and quality space. And then others are doing, device management and working on kind of individualistic processes that way. So
that's a very good background, a little setup for the history behind human factors. I know that everybody has a story. Everybody has a story how they get started. And I know from a fact that you're a continuous lifelong learner. So what's your story? How did you get interested in the healthcare area altogether?
No, so my father was a PCP growing up, and so naturally
that is a
primary care provider. Sorry,
exactly right.
Typical general practitioner.
Yep.
And so growing up, wanted to follow in his footsteps, that sort of thing. When I was 14, he and I were in a really bad car accident, and he unfortunately didn't make it. But I ended up having over the years since that, it's been about 21 years since then, about 16 different surgeries. And so I became really close with the orthopedic surgeon who did the majority of those. Ended up working for him as kind of a medical assistant, trying to kind of begin into prep. And so when I started my undergraduate at Texas Tech, I started out kind of the whole pre-med flow. I was always, grew up around it, always been around it, was always interested in it, and then had got a chance to work in it in a number of different domains. And so it's kind of been one of those things that has always held, I knew I wanted to work in the healthcare field, whether that was as a provider or as an administrator, I wasn't sure, but I knew healthcare was definitely the area I wanted to grow into.
Well, it's pretty interesting because today with the students that are in the healthcare leadership and management programs at UTD, here at our university and other places, they're really trying to figure out what their role might be and what type of leadership role they might end up with and how people might mentor them and give them guidance. So it's really interesting to see how that highly influenced where you ended up. I think you also, didn't you work at NASA for a while as well?
I did, yes. In grad school, we were required to participate or to complete an actual industry internship. It couldn't be at another university. It couldn't be, working for your graduate advisor. It had to be, go off into the world, and complete this internship that you had to meet certain requirements and that sort of thing. And so I actually ended up getting on with Lockheed Martin down at the Johnson Space Center down at NASA, and ended up working in what they call the UTAF, which is their usability testing and analysis facility. They have, I would say at the time, probably 8 to 10 formally trained human factors engineers that were working on a variety of different projects. At that time specifically was when the Constellation program was in full swing, when they were, everybody knew the shuttle was retiring. We needed to develop a new means to get our astronauts back into space. And so where I focused on was with the crew medical officer. So I was able to still kind of tie into a healthcare kind of domain in terms of how it applied to long-term space travel. And so we helped develop some tools and techniques on, if I have a handheld device, and this was back in 2009, so, smartphones and everything were around, but not quite as prevalent as they are today. But if I had a handheld device or a tablet I could strap to my arm, if I'm the crew medical officer and somebody gets injured while we're up there, I have algorithms and things that I can walk me through how to treat this person, be it kind of, you have a boo-boo that needs a Band-Aid versus, you have a severe concussion, we have to get you back now. And so we did some research around what's the best way to present that information, how should the tool work and use, how would the crew medical officer use that, and then also convey with the flight directors and things like that back on the ground. And so it was a really interesting internship for sure, and learned a lot and got to see a lot of different applications of human factors, not just in healthcare, but outside of that into a kind of a huge industry giant that Lockheed Martin is.
So you'd recommend internships to students today?
Absolutely, yeah. That's and that actually is what, mine kind of all tied together that way because, I was looking for, while doing the internship, trying to come up with ideas that I knew I wanted to research as part of my dissertation. And so that kind of led me down the idea of, this is when electronic health records were kind of first beginning to roll out. And I knew that was obviously going to be a huge deal. It was tied into the, the Affordable Care Act as part of incentive programs and all of that. So everyone knew they were going to eventually have to get one. And so by being able to work on some of those electronic components while I was at the internship, I kind of developing ideas on, I probably want to go in the area of designing, how do we design these systems and technology with the human factor slant on how to support people and help them make the right decisions and order the right lab tests and medications and things like that. So it kind of spurned an idea that I was able to take on and collaborate with a hospital in Kansas City. But it all started with that internship, trying to figure out, academia, research and all that stuff is critically important. But if I didn't want to go into academia, I wanted to go into industry. And so it gave me an idea of how to interact with those folks and what kind of data are they looking for and how do they want the data presented to them or your findings and recommendations. So it gave me the kind of touch of industry experience that I just wouldn't have gotten otherwise.
Very good. Well, let me try to set the stage here a little bit for how this human factors really plays into the real world that you live in. So you're at Baylor Scott and White, and everybody wants to go to the hospital, right?
Right.
Yeah. Right. Well, they do when they need a lot of help.
Absolutely.
But certainly understand that patient safety has got to be of paramount concern today. I know that one of the big initiatives is looking at value in treatment process, giving the very best treatment, eliminating errors wherever possible. So I could see where some of this, ability to think through processes and understand the best way of doing things, best practices being developed. How do you go about making that user experience a little bit better, not only for the people that are the service providers, but also for the patients?
Absolutely.
Looking at some of the risk factors, how do you mitigate some of these risks? You mentioned the electronic health records. Nothing could go wrong there, I'm sure. And medication control. Today with the Internet of Things, the refrigerator can order milk.
Right.
So, are medicines and things like that being handled with IT? And so how does this all kind of factor in with the human factor component?
Sure. So, and that's why I like being kind of embedded in a quality role, a quality safety role at Baylor Scott and White. And so, the bottom line is no one goes to work in the morning going, oh man, I can't wait to give this patient the wrong medication. No one goes in no one wants to intentionally go in and hurt people. However, healthcare is so complex and there's so many different things, and it's only becoming more so, right? With numerous specialties, numerous different technologies and different processes that people can use. We're kind of setting a lot of folks up to fail. And then what administrators need to understand is that, yes, there are, and it's not to say that when an error is made that someone's not culpable. There are instances, of course, where someone just completely chose to ignore protocol and procedures. They took that upon themselves, and then an error resulted. But the vast majority of the time, it's when people are just trying to do what they think they're supposed to be doing, or they're trying to work within a work system that is broken. That is set, that they're saying, the administration comes in and says, you have to use this type of electronic health record, you have to use this type of barcode scanning medication, or whatever it may be. But no one really looks at it from kind of, I keep using this term work system. And when I say that, what I mean from a human factor standpoint is the intersection of, the people, our policies and procedures, our own cognitive limitations, the technology we use. So a lot of the times we sometimes hamstring ourselves with policy that sounds great on paper, but where the rubber meets the road, there's a huge gap in healthcare between what the leadership wants to do, and they don't want people to get hurt. They don't want to lose money from unreimbursed care from CMS, Center for Medicaid and Medicare Services. But at the same time, they have to operate within the budget. And so one of the things that the government has began shifting to, as has been, well, if I go to get a surgery, and then I develop an infection while there that otherwise would have been preventable had I not been at that facility, we're not going to reimburse you for the care, for the antibiotics, for the care, whatever it may be. And so that's why a lot of healthcare systems, it just naturally is, if we have to keep our lights on, right? And so a lot of where human factors really fits into that is kind of saying, okay, well, we know where people are naturally going to make errors. We know what situations, that our providers and our nurses and patient care techs and all of these folks we know the work system they're operating within. How can we go in and look at it from that standpoint and redesign the work system to help support them, number one, to not hurt people, but number two, to help avoid some of those financial penalties that may come that you're just simply not going to be able to keep the door on. If I'm paying out $3 million a year in penalty, or if I'm having to absorb $3 million in unreimbursed care because I have a really bad, central line associated bloodstream infection, a CLABSI rate, for example, then it's impossible for me to kind of keep operating and growing my brand. And so that's where healthcare and human factors have really met. And it's become so popular. When I first started in grad school, you could go to the National Human Factors Conference, the yearly conference, and you might see one or two talks that might have something to do with healthcare. It's become so popular over the last 10 years, or I guess 12 to 15 years since then, that it now has its own spin-off Human Factors and Healthcare Conference for 3 days. So, and health systems are really beginning to realize that not only can human factors engineers help improve safety and quality, improve patient experience and staff satisfaction, but they can also help us avoid some of these financial penalties that are just going to, make us have to shutter our doors, basically.
So it's quite obvious that this has a huge factor in terms of profitability and operations within an organization. And there's probably many, many, many areas. You mentioned a couple, like, electronic health records and medication control, but, the surgery environment, the inpatient environment, this overall workflow process probably expands all the way throughout the organization. And every place that you make improvements, there's the next stop to make more improvements. It's a continuous improvement process.
Right.
So I think this kind of leads up to the concept of some type of culture of safety, a new way of thinking. Mm-hmm. How does the organization embrace this new way of doing things? It's really a culture of risk awareness as well. Mm-hmm. People should constantly be aware of what they're getting into and why they're getting into it. And really kind of leads up to decision support for healthcare, mm-hmm. more advanced decision support systems. And that brings up a question. Is there trust in getting these decision support systems? We've all heard of Watson, the IBM supercomputer that basically can give you advice and direction. Well, maybe not so, but it can beat you in jeopardy if it's played right. Absolutely. So these decision support tools, are they being widely accepted in the business side of the house?
That's, my master's thesis was actually on, one aspect of that, and this was back, in 2009-ish, I believe. So things have changed quite a bit in those years. But one of the huge things that providers and administrators were worried about is that it was coming out that patients weren't really all that fond of their providers using clinical decision support. I think it's, as it's become more mainstream, Alexa and Siri and all these things, I can ask it and trust what it says to me, supposedly, that's not quite as big of a barrier as it was. And so then you begin to look at, okay, the number one issue, in my opinion, from a human factor standpoint, is we have all this, we can develop these fantastic algorithms. We have all this computing power. We can look at big data. We're currently in talks with a vendor that has that capability that can pull in not only just patient's vitals and lab results and all that stuff, but can also look at their social economic status and where are they from. And it compiles all these things and says, okay, this patient may be at risk. I'll just make something up, but this patient is probably going to be at risk for being readmitted within 30 days because of these 6 factors. And then because they have these huge decision support algorithms and things, they can say, well, because of those 6 factors, we recommend that you do A, B, and C, 3 things to help prevent this from occurring. And so people begin to trust that. But if those alerts and these things fire all the time, then I'm just going to blow through them, right? Natural, we call it alert fatigue in human factors. It's not an unusual term. But where my biggest concern, honestly, there's a genre of research in human factors that's called automation bias. Basically, the easiest example is there's several unfortunate examples where pilots began to simply they trusted the alerting that was coming through from the cockpit. They were trusting the algorithms or the dials that said I'm at a certain altitude when it was obvious that they weren't. But they were so reliant upon those systems that when the system breaks, and then says, nope, I can't handle it. Human, here you go, human. Now you're back in control. And that human hasn't been kept in the loop throughout that whole process. Then we really, it's not uncommon or unsurprising that we would have a huge catastrophic error, like a plane crash, for example. On the healthcare side, providers have become so inundated with alerting and, CDS and, this patient may have an allergy to peanuts. Well, was it really an allergy or was it just they say I itched and it's really more of an intolerance? So there's a lot of nuance in terms of how you design these decision support systems that are meaningful, that don't inundate providers with a million different alerts per day. But they're also, when they actually come, that they're actionable, not just, hey, this patient may have an alert or may have an allergy to this particular medication, but nope, here's, the patient has an allergy documented. We recommend this as an alternative. So it's where they can, from the same screen, same workflow, just, okay, I'm now alerted to this. Now I can switch what I was going to do because of that. One thing I am a little bit nervous about is because, you have this whole new generation of physicians and nurses and everyone who's grown up in this clinical decision support era, that they're going to be so reliant upon those alerts that kind of the same thing when a plane crash happens. If the system breaks or if it's incorrect or something like that, and then they just keep, the computer told me to do it, so it must be right. Yeah. And so they just blow through it, and then somebody ends up getting hurt. So there's you got to be able to walk that balance beam of, you don't want to inundate them with a bunch of alerts, but at the same time, you don't want them to become completely reliant upon them either to make their clinical decisions.
Yeah, the artificial intelligence AI argument is in place today. You hear profound leaders saying that AI could be disastrous, and other people are saying that artificial intelligence could be one of the great decision support tools out there.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
I know that you're well published. You've done a lot of research and you've looked in a variety of areas. And one thought that I had was in the nursing work system that you've talked about. I think we all believe that nurses, they're the foundation of caregiving, and the bedside quality that they have and the safety practices that they have. When you look at improving the nurse efficiency, when you look at these time and motion studies, that's a real big human factors environment, I would think. Tell us a little bit about that, what you've seen.
Sure. So the project you're referring to actually started several years ago at the legacy Baylor system prior to the merger with Scott and White. And it literally started off where the CEO of the legacy Baylor system, Dr. Rosemary LaGuire, called up my cell phone one day in the evening and was just like, hey, our our nursing satisfaction scores are falling, but their patient to nurse ratios are maintaining at a 5-to-1 for a medical surgical unit, or maybe a 2-to-1 in our ICUs. And so we're not really sure why they're saying they're not happy, why they're saying they don't have enough time to do their jobs, or they don't have enough resources to do their jobs. She goes, I think that's a human factors thing. We go see what you can find. I was like, okay. And so it led to this huge year-long project at Baylor University Medical Center, our big flagship hospital in downtown Dallas, that was really trying to say, okay, what is it that nurses are really struggling with? We know what's happened to nursing, unfortunately, is that as resources have continued to shrink, and full-time staff have continued to shrink, and staffing is really monitored at the minute level in terms of, well, we're going to have to let you go today because we don't have enough patients. Our staffing matrix says that you have to go home, that sort of thing, where they just don't have the resources they need, and they're asked to do more and more and more with patients that are more sick than they've been in the years previous. And so where human factors came in is we went in and we spent a lot, I don't know how many hundreds of hours just watching. The biggest thing you can do in research, from a healthcare leader, in my opinion, the best thing you can do is to go out and actually see what your staff are doing. Because you can sit around a conference room table and say, okay, tell me what's hard when you're passing medications that really slows you down. Well, you might get some good answers, but for the most part, humans just aren't very good, especially if we're experts in a domain. We're really, really, really bad about trying to explain what it is we're doing when we're doing those tasks. And so observation, that's been kind of one of the biggest things I've harped on at Baylor, is that, okay, if you're a leader and you have these issues, or you're hearing this from your staff complaints or something, yes, meeting with them is good. It shows that you're listening, but going out and watching them do their work, and so you can see, oh, wow, look at all this stuff going on. I think an easy example, part of that publication was at one of our universal bed units in Grapevine. We did this project there, and then we noticed that, so they had 2 medication rooms, just because the way the hospital was designed. It had really, really long hallways, and so with kind of a nursing unit on kind of one end. So it wasn't a central located, it was kind of on one end of the hallway, then really, really long hallway with just patient rooms all the way down. And so they're like, we're going to help out our nurses. We're going to give them an extra, automated dispensing machine down at the other end of the hallway. That way they're not having to walk back and forth and spend all this time doing it. Well, that's a great idea, but when they went to implement it, they just kind of stocked it with, okay, well, this unit uses X number. Pharmacy ran reports and was like, well, y'all use this many of this type of drug, this many, so we're just going to stock at that. But then what happened was both the dispensing machines were stocked separately and differently by different people, and so nurses weren't sure which machine held the medicine they were trying to pull, as an example. And so then they would go to one, and hopefully, if it wasn't there, like, dang, then they had to walk all the way down the hallway to the second one, and then hopefully it was in that. And then if it wasn't, and it's like, well, now I got to call pharmacy. Well, then pharmacy says, no, we tubed that up an hour and a half ago. And so there's just this huge cycle and so by going in and actually watching them try to go through this process, we were able to really standardize, standardize how those were stocked. When they were stocked, sometimes a pharmacy tech might be up there at 8:30 in the morning, just because that's what time they can get to it. Well, that's right as nurses are getting ready for their 9 a.m. med pass, which is the busiest and biggest med. So they were having to wait on the tech. And so there's a lot of different things that you wouldn't normally find. And when we went to go actually talk with nurses, and we had a survey and things like that we asked them, that did not come up at all. It wasn't even on a radar of somebody saying, when I go to get my medications, I noticed that I have to go to this whole completely dispensing machine. And during this project, by just doing some of that, looking at it with not adding new staff, we didn't add 3 extra nurses per shift. We didn't add, a lot of extra resources. We just said, well, let's look at this work system, how we can redesign it. And by doing so, I think we saved them over an hour a day of just in the med rooms, and we were able to do that. They had nurse locators and things that we were able to pull that data from. But until you get out and see it, stuff like that just doesn't materialize.
Yeah, that management by wandering around, it's kind of like leadership by wandering around, getting a chance to look at some of the different things that are taking place. There's a lot of different topics that we can talk about, from the electronic health records to the nurse work process, banding people with ID tags the right way. There's a gazillion ways that you can make a mistake.
Absolutely.
And really what this human factors message is really about establishing a whole new mindset that's really looking at the process improvement, and the quality. So I know that you've been a lifelong learner, and you currently, you have a PhD in human factors, and currently you're enrolled in a Master in Health Leadership and Management at UTD. You'll have more degrees than a thermometer by the time you're through. So that's pretty interesting. What was your interest in pursuing a master's degree in healthcare leadership and management?
Yeah. So when I started at Baylor, I was fresh out of grad school. They threw me 100% into, even though I'd come off the street, knowing a lot more about healthcare and workflow and terms and all this stuff than like a typical layperson might have, just because I grew up in the field. They said, go out and learn everything you can via these applied projects. But, Baylor Scott and White has 45,000 employees. We may be getting much bigger with another merger that's looming on the horizon. And I quickly realized that, there was one of me and there was 45,000 employees, and they want human factors to be able to help support, not obviously not a one-to-one ratio, but, hey, like the nursing work system, for example, there's a million projects like that the administration and things want done, or that we just need to have done from a safety and quality perspective that I just didn't have the bandwidth to complete. And so what I learned, about maybe 3 years into my role at Baylor was that, okay, if I really want to have wide-reaching impact on our quality initiatives and our safety, yes, doing these one-off projects are great because it helps that unit, and then they can help spread it, hopefully, that sort of thing. But I learned that if I really want to have wide sweeping change, I have to start climbing through the organization. That way I can help steer these larger initiatives, these larger projects, by kind of infusing a human factors approach through a lot of the work that we're doing. But, I'm able to have a much broader reach in terms of doing that. And so, but as an undergrad and then in grad school, I had zero leadership and business training at all. And so I began looking around saying, okay, well, if I want to start to climb, I want to learn how to administrate, how to be a leader, how to, look at finance, budget sheets and things that I just had no training in. I knew that I needed to go in and kind of get a training in that way. So I'd originally looked at just a typical master's in healthcare administration because that's most common, I think. And when I talked to Dr. Thurgood here, he said, well, yeah, you could do that, but we have this new healthcare leadership thing that's more about leading adaptive change, and how do you really implement this as a practitioner of whatever it is you do at your organization. And so to me, it seemed like a really good fit, and I've already been able to apply a lot of the things we're looking at. But what that's also given me is a tool set to say, okay, I now can run some of these huge system initiatives that span 40 hospitals. But I'm able to do that because I've learned these administration techniques and tools, but then I can also infuse into those projects the human factors side too. So I'm able to, exponentially increase my bandwidth and having impact on patient safety.
Yes. We tell all of our students today that, the healthcare industry is going through change. That's not a new headline. I think everybody realizes that. There's a lot of areas that are broken. Mm-hmm. There are a lot of things that need to be repaired. There's a lot of innovation yet to take place, a lot of technology to take place. A lot of the work process that you speak of needs to take place. Mm-hmm. And when asking the question, what's the future of healthcare? How do you see the future of healthcare? We asked Dr. John McCracken, who's been running the Alliance for Physician Leadership for the last 2 decades here. He works exclusively with doctors. Mm-hmm. We asked him that question, what's the future of healthcare? How do you see it? And he says, the long answer is, I don't know. That's the long answer. The short answer is even shorter. But I'll ask you that question. Just as a general consensus, you're moving up in the organization. You have a bright future in front of you. You see a lot of opportunity. What's your prognosis here of the American healthcare system going forward?
Ooh, yeah. We do know for a fact that people are getting sicker. Right, the patients are becoming much more complex, and we do know that the new model is going to be not so much of a centric inpatient facility, but a lot more kind of outreach and preventative medicine via clinics through like primary care providers, for example, or things like that. And so what I think healthcare leaders are going to have to understand is, okay, well, how do you because you make your money off of your procedures, right? Your surgeons, your surgeries, your endoscopy labs, interventional radiology, all that stuff is where your bread and butter of income comes from that helps support all the other initiatives. And so they're going to have to figure out how to, if that is draining, if we have less people spending time in our hospitals, inpatient, and are having, hopefully being able to prevent through some of this preventative medicine approach, some of these procedures that they're going to maybe end up having, how do we then begin to kind of share the business model with this outreach type of an infrastructure? And so that's something I think we're still trying to figure out as well in terms of, if we have all of this technology that we can use. And I see big data being a big piece of this. And this where earlier mentioned the clinical decision support is if I'm a primary care physician, you're coming in for your yearly physical, it combines all this stuff for me and gives me algorithms to make sure that, hey, did I touch on diabetes management? Did I touch on smoking cessation? Some of those really easy ones. But then also on some of those, okay, because of where you're located, because of your economic status, because of your background, all this data we can pull together, people like cohorts like you throughout the U.S. or even more specifically throughout this region are going to experience these problems. And so we're going to have to be able to tap into some of this big data and some of these huge algorithms that are being built, but at the same time with a human factor slant, if you will, in terms of presenting the information in a way that's, number one, actionable and meaningful, but in a way that also that providers can engage patients and say, because patients are just going to have to take more responsibility for their own personal health, right? And so how do we engage them and present them information and give them the tools they need that while they're not, that we can keep them out of our doors, but at the same time still be able to generate revenue by having these kind of smaller regional clinical type approach versus a huge 1,000-bed inpatient hospital.
Very good. Well, we've had a very exciting session here with Dr. Adam Probst. We've really enjoyed the time and the ideas that you shared with us. So thank you for being part of our podcast.
Yeah, thank you for the opportunity.
Thanks for listening to the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find episode links, notes, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jindal.utdallas.edu and then search under the Center and Institutes tab on the navigation menu. Also, we want to hear from you. If you'd like to provide feedback, make suggestions for future guests or show topics, or just want to get in touch with us, email us at healthcarebizpodcast@utdallas.edu. Biz is spelled B-I-Z. And let us know how we're doing. I'm your host, Dr. Bob Kaiser, with the Center for Healthcare Leadership and Management, where we're leading change by changing how we lead.